Hey, most of y'all know me, but I'm Michelle Dawson, and welcome to First Byte. If you're new here, you picked one hell of an awesome week to get started with us. If you are a repeat flyer, huzzah, you're back. uh, in all honesty, I'm a very tired mommy today who just turned 42. So thank you for joining me for my birthday week episode. Um, Y'all, today has been a joyful day of taking care of our tiny humans who survived apparently a new diagnosis of migraines associated with teenage hormones and panic attacks getting a cavity filled when you're 10, which is hard. Also, nitrous oxide with a tiny human is hysterical because the same look crossed my 10-year-old's face as crossed Fatty Patty, our cat, when my husband sneaks him too much catnip. So, like, yeah, he's over there. He's listening to all of this. But uh, in the last month, I have seen so much joy in our pediatric feeding disorder community, which has done my heart good, especially when it kind of feels like I'm watching the world burn every time I turn on the news. But last week, I had the opportunity of lecturing at the University of Tennessee, the Knoxville location. And so, Maggie, thank you so much for inviting me. The Saul Adler Memorial Conference was phenomenal. But y'all, this this clinic is everything that best practice should be for a graduate level speech language pathology program. One, I don't know how they do it. Their cohort, holy crap, they have 60 graduate students a year accepted into their cohort, but their faculty and the space that they have created are uniquely equipped to meet them. So paint a picture with me and imagine going to grad school right now and you have an adult dysphagia specialist who does rigid scopes and treats in the university clinic laryngectomies, or you have a adult dysphagia clinical faculty member who does fees right there in the clinic, or you have two pediatric feeding and swallowing specialists, so Maggie and Brianna, and then they have this lovely woman, Justine, who got me coffee. And oh my God, that was the best cinnamon dolce coffee that I've had in a minute. And she's their AAC specialist, complete with this room that another lovely student who I got to meet and asked the greatest questions completely redid. I'm not saying her name because of FERPA, but the room was completely redone with low tech to high tech adaptive books for AAC literacy immersion, every brand possible, so that there's no implicit bias when working with AAC. And that's just resources. Then, when it comes to the actual clinic space, this place had an adaptive indoor preschool classroom. A playground with spongy floors. I totally stemmed. They could drop the lighting. They had, God, anything you could want, as well as an early intervention team. This This is best practice. This is serving your community. And don't worry, I asked them if we could do a podcast episode because I was like, you guys have got to come on for this because this is just, God, it was humbling and electrifying to see the progress that our field is making towards training the next generation of speech pathologists. So I have a birthday request. And I know that I say this every, I don't know, however many episodes. If you have not yet served as a clinical supervisor, please, please, please reach out to your local college, graduate program, undergraduate, um, and offer your time. Reach out to the clinic director, reach out to the clinical practicum coordinator and say, hey, I've been at this for so long. Shoot them an email. This is the area that I focus in, or this is my specialty area. And please, please, please see how you can volunteer your time as a clinical supervisor, because they are serving it profound on campus. But not every program has those luxuries. Not every program has those resources. And that's where those of us that are in the community can fill the gaps. So my birthday request is that you take a leap of faith with me and take a student on. And if you're already a clinical supervisor, then my birthday request is, reach out to Feeding Matters. Reach out to your favorite nonprofit. See how nonprofit. Oh my God, it's been a day. Hogtied 2 children. We're good. We survived. But reach out to them and ask how you could volunteer with them. Because the tiniest amount of time you can wiggle into your schedule could make the biggest difference for a tired caregiver or a clinician on the other end that's just tiptoeing into this field. So that segues me into our guest today, the one and only Miss Tiffany Elliott. Miss Tiffany Elliott is not tiptoeing into the field. Woman's been at it for a minute, but she is a quiet powerhouse. I am a joyful hot mess express. If you meet me and I'm at a conference, I'm probably pacing because ADHD, neurodivergent brain, I can't sit still, right? Tiffany is demure before demure became a fun word, right? When she speaks, it is with wisdom and depth and kindness. I had never met Tiffany before in my life. Barbara Coven Ellis from out on the West Coast introduced me to Tiffany via email chain. She was like, Michelle, this woman is doing best practice. She is taking all of these NICU patients and helping them bridge over into early intervention. Her program is profound. And that's how I met Tiffany. So imagine my surprise when months after I have interviewed this fabulous woman, because we batch record in advance, I'm sitting at a lovely little restaurant in Phoenix, Arizona with my sweet friend Jennifer Castex. And we're sitting next to these 2 women, and I'm like, God, she looks familiar. But again, I'd only met her like virtually through Zoom. And she was like, I'm Tiffany. And of course, I squealed, almost spilled a drink. It was good drinks. They had lovely drinks at this restaurant. And we got to, jabbering and catching up. But she carries that quiet strength with her in all settings, whether you're spontaneously breaking bread or, I guess, tortilla chips and amazing guacamole together in Phoenix on the fly, or if you're sitting there asking her about how can I best serve my patient. So I truly hope that you enjoyed this week's episode. If you'd like to learn more from her, I can tell you right now until April 1st, she and her partner, the psychologist that specializes in maternal mental health, have a webinar through Feeding Matters that you can access. So I know this was a longer intro, but it's so many wonderful things have happened to instill hope and make me optimistic that we are continuing to go in the right direction, even when the rest of the world may say nay. And for those of you, that was my son dropping something, not anybody farting. But for those of you that are interested and nerdy, I'm turning 42, which, if you've ever read The Hitchhiker's Guide to the Galaxy, you will understand is the answer to everything. It's not the question, but it's the answer. So happy 42. Thank you for joining us and enjoy the episode. Okay, everybody. Thank you so very much for joining us today. We are truly in for a treat. Today's guest is none other than Tiffany Elliott. And she comes to us by way of our sweet friend, Barbara Coven Ellis, also known, she's got the SLP detective with like the unicorn logo. I love her. And she wrote a really good book. So, I have it at the clinic because I use it with my patients. Tyler Takes a Taste. But Barb was like, I know this phenomenal speech pathologist that set up this great program. You should have her on. And I was like, okay, I trust you completely. But I have to read her behind the scenes email because it is truly the most kindest affirming. If you're ever having a bad day, Tiffany, this email is for you, okay? So, um, hey, Michelle, I know you're super busy, but I just wanted to put a little bug in your ear about the interview that you have coming up with Tiffany Elliott. I'm sure you'll be talking about the H2H hospital to home program she developed, but I wanted to give you just a bit of history about this amazing lady that I'm sure she wouldn't divulge on her own. University of Washington and Seattle Children's are our two big NICUs in Seattle. Interesting, Seattle Children's NICU didn't use SLPs. They use PTs and OTs. This is the home of a lot of great leaders, but no SLPs. Tiffany went from UW, where she'd done marvelous things, to Seattle Children's Hospital, where she developed the program for SLPs in the NICU there. While she's on the quiet side, she is a force to be reckoned with. I'm very fortunate to know her, only because she reached out to me one day on SIG 13. Otherwise, our paths would never have crossed. Living on different sides of a very large body of water, and Washington have, shall we say, room for professional growth and a partnership. She's amazing. She's done totally cool stuff and continues to do so. Absolutely the kind of person who says your name into a room of people that can help lift you up. Hmm. So I don't know you, but like, woman, that's a lot of love.
That
And
is a
she
lot of
didn't
love.
hear this, so I totally threw this on her. So hi.
Hi.
Yeah.
Wow. What a way to start the morning.
Uh-huh. You are loved. There's Jesus in your teacup.
Most definitely.
Yes, but so that's what I know about you. Beyond that, nothing. So take us from the top, ma'am. Who are you?
Um, so my name's Tiffany Elliott. I am a speech pathologist by training, and I'm also an IBCLC, so lactation certified, and have a few other credentials, like certified neonatal therapist and neonatal touch and massage. And really, my quest for knowledge and learning really continues to come from working with families and working with lovely professionals across the continuum.
Yeah.
And I really have a passion for and access for families and for therapists. I see that knowledge across the continuum of care, and I've been really fortunate to be in a variety of spaces, um, and ask the questions of why not, and see what we can do for these families and these clinicians. So.
Yeah. So how did you pick this profession? Because that's something everybody's got a story on how they became an SLP. Because I did have a panic attack and thought I would be a lawyer. And then my dad was like, I'm not paying for that level of college. Suck it up, buttercup. finish, finish school. So like, ta-da. But
Yeah.
also I don't think I would have liked being a lawyer in the long run. But how did you choose speech pathology and then move into the world of the NICU?
So I actually didn't know what I wanted to major in for quite some time, and I pushed up against that. Well, you need to decide because you're in year two of
Yes.
of your undergrad. So I tried a variety of different things, thinking I'd be a teacher or a counselor or even a music therapist. Um, Tried my hand at accounting because that's in my family's history. Everyone's in business.
Cool. That
But I
sounds
went to,
painful. I'm sorry. Staring at my
yeah.
husband has color coded our spreadsheet in hopes of making it like bright and pink will like it help. I mean, it doesn't, but it's pretty.
Yeah. And so there was a counselor in undergrad who said, well, here, let's take this skills test. And that's where it really showed that I had some strengths and I had some personal experiences and got to shadow different speech pathologists and really saw that that is a space I wanted to lean into.
Awesome. So
Yeah.
The NICU is a setting that I know a lot of young graduate students want to like break into. How did you break in? Because that's always like, well, how did you get there? What did you do? What extra work did you manage to succumb to?
Yeah, so I just showed up and asked questions and was curious. And I actually didn't know about the NICU and speech pathology until we had more conversations and we had to pick a research project. And um, one of my placements I got to do was at Mary Bridge Children's Hospital, which is down in Tacoma. So I would drive from Seattle down there
How
and
far
really
is
got
that?
it's a good hour, but
Oof.
thankfully a reverse commute. But got to experience a variety of settings across, acute to outpatient and older children, and really found my love in that NICU space.
Mhm.
So I was fortunate to then get my externship there, so I got more time, and then got hired on as a clinical fellow and started my career there. And really started from the outpatient setting and then really raising my hand when who's interested in this in the NICU and yep. And just being there and absorbing and learning. And I can still remember stepping into that space in the first few times going, wow, this is a space many in this world don't know about. And our families and babies find themselves in this space, relying on these people to help them. So that's, yeah, just gradually over time and then really building my competencies and confidence um, across different continuing educations and having conversations and really listening to the families themselves. So,
Yes. One of my girlfriends, Dr. Erin Kleiner, calls it the helium hand. That we just, and
mm.
she's not wrong because all of a sudden you're like, what did I just do? Like, helium hand. Yeah.
Yeah,
Ah, well, I got to
yeah.
be honest. I could not work in a NICU. Bear was, both of my babies were preemies. 36, Goose was 36 after labor stopped 7 times. And Bear was 35 on the nose. And I think we had labor stop 13 or 14 times to keep him
Wow.
in. That child, he hadn't stopped since he was born. So like it tracks, right? Like 10 years later, still tracks. But he was in the NICU for like you have like the set time that you have to be in when you're a preemie. Um, he was the biggest baby in the NICU. He was 6 pounds, 12 ounces at 35 weeks. And I mean, my husband waited till I was pregnant till he told me he was a 10-pound baby. I was like, you have lost your mind. 'Cause that's not going to actually, even the OB was like, if he cooked any longer, we would have had to have a C-section because you would not. I'm like, yeah, well, yay for preemies. But because of that, and I had always been kind of curious about it, right? Like living in
Mhm.
Columbia, there was a couple of NICUs in town, and I was always kind of curious, having come from the early intervention world, is this something I would like to go into? But sitting in the wheelchair, having been not a C-section, but we had what is it when they blow out your booty? Is that a grade 4? I don't
It
know.
should be, right?
He's the
If
reason
it's
I
not.
giggle fart. Folks, you're welcome for that insider knowledge. But like, sitting there in the wheelchair watching this giant baby in the NICU was all the affirmation that I needed in my soul that this is not the setting for me. And it takes a special calling to work in that setting. So to you and to everybody else that works in the NICU on from this side, thank you. Not just professionally, but also wearing mommy hat because that just yeah, thank you. But while you were there, you set up something called H2H, the hospital to home program. Am I using this? Hospital to home systems change. So, what is that? Because it sounds fancy.
Yeah, so my journey from actually was at Mary Bridge, and then I went up to UW NICU, which Barb mentioned, where I helped co-found the speech pathology program in that NICU. And we went from not having SLPs to full-time 7-day a week coverage. So actually in that space is where I would see we would provide this amazing supportive neuroprotective care and
Wait, what does that
neuropromotion.
mean? Neuroprotective care.
Really being mindful of how you're interacting with the baby, and I take it to the family as well, but and really promoting neuro wiring, because there's thousands and thousands of neuro connections that are made every single minute from 26 weeks to 40 weeks gestation. So if you think about the impact every single minute and every single interaction has with the infant, and again, I take it out to the family, that
Mhm.
actually is helping them wire certain connections together in their brain and helping them prune other areas they don't use. So really thinking about promoting optimal neurodevelopment.
Mhm.
Um, and there's finer definitions along that, but that that is kind of how I approach it. And then I would get calls back from families saying we can't get access to early supports programs. So in our state, in Washington State, it's called Early Support for Infants and Toddlers. They're really trying to shift away from the term early intervention because the thought is intervening is not as it's like happening to rather than with.
Mhm.
And there's a lot of research around like the racial and ethnic and disparities when you use those terms. So we're
Mhm.
trying to use the terms early support. So these families couldn't access care, and there was these huge gaps. And I also didn't have a way to bring them back because I was only NICU and there was no outpatient component because we were a NICU within a birthing hospital, an adult hospital. There was no pediatric. Um, and so that really sent me on my quest to look at improving that transition from hospital to home. And
Yeah.
it has been over 10 years in the making. Um, and and it has been outside of my quote unquote day job, right? So, because especially working in hospitals, it's all about, making sure you see the patients and really provide the optimal care. There's not a lot of space and room to think bigger and really shift that landscape. So really over the last 10 years, there's been a lot of conversations with people in the community and different stakeholders coming together. And this has evolved over time. And this hospital to home systems change has really only been in the last couple of years. And that is a job that I get to do with Northwest Center, which is an ESID or early support program. And we really are working on improving the different areas like the hospital side, the home side, and really looking at advocating with that lens of perinatal mental health and really that emotional well-being. So I've had these different jobs, and this is my passion, um, because I believe that wherever you live in the state, you should have access to quality care, timely
Yeah.
care, and really inclusive, holistic care. And yeah, I'll stop there because I know I've shared a lot in that moment, but that's
No.
I
It
was there at the NICU for a while, um, and yeah, that's how it all kind of started. Um,
Yes. So, coming from the other side of it, in South Carolina, I did an early intervention for the better part of 12 years. Um, Even when I was working in academia, I was still doing early intervention, because at Francis Marion University, which is located in Florence, South Carolina, the history and geography of the land is pertinent to how you practice, right? So,
yeah,
yeah, so in South Carolina, historically, when the end of the Civil War occurred and they freed the slaves, a lot of the free slaves were given land just east or around I-95. And it's called the I-95 Corridor of Shame, because it is some of the poorest quality land for growing crops, right? So now you have uh, redlining district at its finest, right? So now you have generational poverty up and down I-95. And the way the school districts are funded in South Carolina, the income tax from homes funds the schools. So it begats this never-ending cycle. So 15, 20 years ago, there was something called the Abbeville School District lawsuit, where the schools along the I-95 corridor of shame sued the state for equitable access for funding. Still hasn't been resolved this many years later because
Yep.
racism, let's call it what it is. But all of that being said, Florence is right there. So Florence is a flow town. It's also it's on a fall line, so like water, like it's close. You can carry a boat inland, right? It's typically how major settlements were kind of founded up and down the East Coast. But anyhow, Francis Marion University is right there, and because of this, they have such an impoverished high need for BabyNet, which is what the state early intervention system is called. So we were able to make the clinic a designated EI provider because there wasn't anybody. So we would do home health, some, as well as have families come for outpatient services. But it was very challenging to, find somebody who could treat pediatric feeding and swallowing disorders post NICU, because at this stage of the game, it is
Yeah.
PFD chronic, because
Yes.
for the most part,
Yep.
it's lasted more than 3 months. But there's so few programs in South Carolina. So it was like this, if you look at the tapestry of the state and the geographical challenges, that was why there was such a breakdown in South Carolina from hospital to home. But there is no program for this there. So I'm hoping people will listen, not just in my former Palmetto state, but across the country. But given that insight, can you give us some of the tapestry of variables? Because I know nothing about Washington State. I mean, other than we have ASHA there, or I guess technically this is airing post ASHA, so we had ASHA there, but but what are some of the barriers that you find across the state, and history of the different regions? Can you share that with
Yeah.
us?
Yeah. Well, one of the amazing things that we've been able to do, my colleague Sarah Cercelli, she's works on the hospital to home systems change with me. She's part of Northwest Center, and she's a family resource coordinator. So in that early support program, providing service, and also has this perinatal mental health background.
What
It's
is that?
when Yeah, it's really supporting that emotional well-being of the parent. Um, yeah.
Amazing.
So really what we've been able to do with this over the last couple of years is try to look at the data. So if we look at what Washington State's prematurity rate is and where most of that preterm birth or the higher rate is, it's a really smack dab in the middle of the state. It's like 2 times greater rate of preterm births than other parts of the state. And then you overlay where the NICUs are, there's maybe one, maybe two level threes in that area. The only level fours are pretty much in the greater Seattle area. And then there's one way on the other side, on the eastern, towards the eastern border. So if you look at that and you also overlay where the maternal OB care settings are, so that birthing parent, where are they getting care? Especially if they're higher risk, they also are getting care in those in the urban settings. So you're going to deliver in those settings, and then you still need to be able to go back and integrate and have services in your community. So that's really what we started to see, and what I would really see on the NICU side, because UW was a level 4, is these families would go back, and depending on where they lived would depend on what access they had.
Hmm.
And that really got us. I would actually start just asking questions to our state ESIT office, like, why is in this county this is what's happening, or in this county. And so that actually led to me getting invited to be an expert on creating our state qualifying diagnoses. which
Oh,
means if you know, it's actually a pretty comprehensive list, and it was an amazing experience to be part of. But if you're born preterm, you automatically qualify for ESIT services in our state.
awesome.
Yeah,
Okay, dude, Bear was born preterm, got nothing. And then
yeah,
bless his smelly little heart, because he's fart central nowadays at 10. He didn't hear for the first 2.5 years. And nobody knew that that was an automatic qualifier for EI services, even myself, but I didn't work with patients that were
yeah.
deaf or hard of hearing. And so
Mhm.
folks, if you're listening, there are legit lists that are automatic qualifiers, most often an ASD diagnosis, a CP diagnosis, certain genetic conditions like Down syndrome, but getting prematurity on there's. What about PFD or dysphagia? Is that an automatic qualifier?
So this list came out before PFD diagnosis came out, and they are in a revision state. So that has been something I've been like, make sure these are on there, right?
Yes.
And so really making sure that that stays updated and really just asking the question. So one of the things I experienced in that NICU when I helped families transition into into home was that sometimes the referral numbers would change. But
What
if
do you
you
need the referral numbers?
like if you live in this particular county, maybe the number to give families to enroll in their ESIT program, that referral number to give them would change. So
That's
like the phone
horrible.
number would change. And I don't know the why behind it, but I started to ask like, hey, can hospitals be notified when these numbers shift or change? Because I that's another barrier then if I'm giving the family the wrong information.
Mhm.
And really just knowing that ESIT is something that the families write. And historically in hospitals, there's this thought that like we need to decide what we share. And we need to, it's actually in a federal law that families need to know that they have a right to this service.
Mhm.
And so, how do we talk about ESIT services or these early intervention, early support services as a right that they have and also a support and not this like your child has a problem, but here is the support that you can get when you're home because we know this transition from this hospital ICU setting into your home is so different.
Profound.
Yeah. And Sarah calls it the service cliff. So, really thinking about there's so many barriers in that transition, and there's not a support.
Okay, so my husband and my oldest love almanacs. No, not almanacs. Atlases. This is the word. Maps. Technical
Yeah,
word. Yeah, hell, I flew out to
not my
Mississippi.
strong
Yeah,
suit
like I
either.
mean, I
You're
went to a
good.
state and didn't even know if I was east or west of the Mississippi and was mildly embarrassed when that got brought up in like a conversation. But when I look at Washington State on a map, there's huge reservations that are there, and it looks like it overlaps when you're talking about the center of the
Hmm.
state. So do
Yep.
you find that when you're looking at the data, does it tell you that there's a higher risk within the indigenous population?
Yep. So that is when you look at the birthing data, that population is, I think, 1 or 2% of all the births, but I think 13% in terms of preterm rate. Like something, it literally shifts. So the way you look at it. And that's one of the things we've been really talking about is the inequities across races and socioeconomic backgrounds and just geographic areas. And that was, I think, one of the reasons Barb and I connected
Mhm.
was like that rural area, different rural areas across the state really have different levels of access. And they're traveling 3, 4 hours to go see their child in the NICU, or maybe once they're discharged, traveling that many hours to go back and receive care. Um, so
Is
that really is
tele
that push. Yeah,
Sorry. Is
you're
telehealth an
good.
option there?
It is. I think the pandemic definitely helped boost that option. Um, I think there's still room for improvement in terms of telehealth and access and but that is an option.
Awesome. I know that there was a rigmarole in South Carolina trying to get access to telehealth services in the pandemic for dysphagia PFD, and I kept getting told, it's not um, viable. You can't ethically do it that way. Pushback from individuals who were not practicing in PFD and dysphagia world. And folks, if that happens, Jean Marshall and oh my goodness, Madeline
Um,
Ratz out
yep,
of
Australia.
Australia. They've done a ton of research on why this is appropriate,
Hmm.
how to do it, and then how to systematically set it up within these kind of systems for success. So if you have barriers for geographic access, this could be a system improvement, but then it's also predicated on the fact that there is infrastructure in like
Hmm.
access to fiber networks and those
Yep,
kind of things. Yeah.
yep.
But I'd like to point out you did a really excellent, beautiful job of sending all of these questions, and we've already gone 14 ways east as
It's
opposed.
great. I love that. I mean, conversations, that's how they're supposed to go, right? Is seeing where we follow that thread. I
Yes.
think one of the things I do want to share that I haven't yet is um I was in the UW NICU for a little almost 8 years. And I know you mentioned earlier, like that's a setting you could never find yourself working in, right?
Mhm.
And throughout that time, I had had my own child. I had had my second, who ended up getting birthed there and having a code called, and the NICU team rushing in, and then them whisking her away. And, I still can remember the count of them doing CPR on her, and then the silent room after. Um, and then the pandemic, and there became a space where, and one of my good friends, so one of my ways of working through all this has been just going on walks and having conversations with friends, right? So, and she said,
Mental
well,
health.
how are you metabolizing all of this? Like, how do you metabolize the stress that you have in this environment and I know, right?
I love how she questioned that because everybody's like, how is your self-care? And I'm like, bubble bath and chocolates ain't cutting it, but how do you metabolize it? That means like it's there's power in that verb.
Yeah, isn't that incredible?
Yeah.
Yeah.
But
So
how do
thanks
you
to my friend
metabolize
Tina.
it?
Well, it really was working on this like improving and making connections. So, um, I would literally call out from this NICU when I was sending families home, and I knew they were in an area where they were going to have more troubles accessing care. I would actually call that ESIT program and really ask some questions and really talk to that provider, and then help manage up that next team for them. So I knew that they at least would kind of get there and then think about those buffers. So that's actually one of the ways that I metabolized it. And then eventually it was really my husband saying, you need to take a break.
Mhm. Bless.
Um,
Bless our
yeah.
husbands or partners. You do you, baby, if you're listening, but find you a person that is your mate that can help you balance that.
Yeah, so I was like, I don't have another job. I don't like, are you sure? And he's like, yes, you need some space. So I actually resigned from that position that summer, and then took a few weeks. I should have taken longer, let's be honest. But I gave myself until the kids went back into school, and here that's late September. And then I started to kind of look again, and that's when I got my current position at Seattle Children's. Um, and I was, like Barb said, one of the first speech pathologists that got to be on that infant team. Myself and my colleague Catherine started around the same time. And what I learned was advocating for myself to actually not be in the inpatient setting to start out. So I started and really still am fully outpatient and then get to go over and float over and do some back coverage and holiday coverage with the hospital setting, including the NICU. Um, I think getting that space and really seeing the families after they went home has really helped. But every time I step into that NICU, I'm like, oh, I want to go back in this full. But yeah, I think letting our path kind of journey and shift is really what has helped me through this.
Mhm. Every once in a while, I get a wild burr up my butt to go back and to do more in academia. And I'm like, oh, I could do this. This time we'll fight the system from within. And there was an eye roll, folks. You couldn't see the depth of the eye roll. But like, you know what I have found? Adjunct is where it's at. Adjunct is where I can adjuncting and guest lecturing is where I can find the
Mhm.
freedom to teach and to do what needs to be done and say what needs to be said with while honoring my authentic self. Because feeling like my hands are tied to talk about my faith, that's part of my culture. That's part of me. Feeling like my hands are tied to not be able to advocate and to do all my little passion projects like this. That's um, soul crushing. So I understand
Yep.
the need to, yeah. Ah, yeah. So I almost hesitate to ask, but I know somebody somewhere is listening to this and is like, look, I work in the NICU and I would love the time to set up or love the time to engage in continuity of care with like the next team or to track down like the EI systems or whatever the system is. But I'm under pressure to hit that productivity number. So how do you find the rhythm there? Have you utilized any of the caregiver coaching CPT codes? Like what is how are you affording that luxury?
That's a really great question. I will say when I was a full-time practicing clinician in the NICU, it really was baby by baby, family by family, and then creating that kind of understanding of what that transition might look like for them and sitting with them to make those phone calls or and that could be like we had computers in the room. So it might not be billable time in that space, but letting them know I'm here with you and we're within a system where I do need to make sure I'm staying on track with writing down what we've talked about. So I might actually document my session while I'm sitting in that space with them and trying to think through what are the obviously what's skilled service and what is billable, and then what is going to help them get that next level of care and actually later on save time and save productivity.
Mhm.
um, that's kind of how I would look at it. And then asking, am I the right person to be doing this? Is this the best use of our skilled service? And what does that look like? And so asking those questions within the full NICU team, and helping everyone understand that it's not just one person or one or the therapy team that does this transition. It really needs to be a conversation from the get-go of how we're going to support them on their way to being a family and being at home. So I don't know if I answered your question,
No,
but
but you did because it's very realistic. So one of the things that I come back to, and I don't know if y'all have it out there, but sure as anything, fight it regularly in South Carolina. And then it is um, a problem here in Virginia as well, is that we have non-licensed individuals within the framework of early intervention acting as case managers and service providers. They could be individuals with a bachelor's degree. In South Carolina, it could be in anything as long as you have a bachelor. It could be in economics, and you are now the case manager, focusing on care coordination and doing early academic stuff like language acquisition. And those folks regularly engaged in scope of practice encroachment. And I would come across individuals with zero training trying to do feeding with my NICU tubey babies, right? Theoretically, that has since stopped, but we shall. Here in Virginia, we have such a dire need of and for SLPs and OTs that work with feeding, that kids essentially just go without. But what I did notice, there's a great big blue jay. But what I did notice is that there's CPT codes and billable codes in the South Carolina manual, and I haven't looked at the Virginia manual, for continuity of care phone calls. So what I found very interesting was that if one of those non-licensed individuals called me to touch base on how therapy was going, when they could just as well have accessed my notes, read them, never wanted to engage in continuity of care meetings, because if we co-treated together, I use that loosely, then they just sat back and watched, but they may or may not be able to bill. But if they called me and kept me on the phone for 8 minutes, and you could time it, then they could bill for that phone call. And I, as the licensed professional, could not. But it begs the question, if the non-licensed individual who should not be engaging in continuity of care phone calls because it's outside of their scope of practice to make referral requests because they don't have a scope, to actual practitioners can bill for that, then can't we as service providers advocate state by state for those codes? Because to me, that would quantify and capture the continuity of care that is utterly required for the work from hospital to EI, from hospital to clinic, for patient safety. So case scenario, but is that an option in Washington State?
That's a really great question. I am not sure in terms of that, but what I do know is there are opportunities to think about before a child transitions. Like, you don't have to wait for the referral to get sent here
Yes.
anymore. They can send it. They can get assigned an ESA agency, and then that ESA agency can start just having conversations with the family and the therapy team.
Yeah.
So breaking down that notion of we have to wait until discharge before that we can even start that process.
Yeah.
So one of the things we have talked through and thought through is, well, what would happen if that care meeting happened prior to discharge? And could we have this warm handoff between systems and really understanding how this family is going to be supported and who their next level of care is?
Beautiful.
I think the other piece of this too is, especially with what you were just describing, I'm so curious. And I wonder, like, how did that become to be, right? So I wonder if those case managers or service providers or wherever they're in this tricky space of these families need support and there's nowhere for them to go. So they kind of start drifting, right? And trying to figure out, well, what level can I provide? Um, and I I don't know about the CPT, but I know funding wise for Part C is what ESID or early intervention is funded by federally. And there's a variety of different mechanisms for that funding. And so depending on how well funded your program is and what other sources of funding you have, there might be that pressure on those programs to find ways for quote unquote billable time. So
That's a
I
good
get
point. I never
curious.
considered
Yeah,
that.
I get curious, like where how and where is this happening? And one of the things we actually have done with this hospital to home systems change work, and when we do trainings, is we actually created a 3-day training. The
Who
Yeah,
attends? When does this
Um,
happen? What are you
well,
talking about?
it's funding dependent. But in 2021, we did a pilot. And the first day was given by our colleague Leslie Butterfield. She's a perinatal psychologist. And yeah,
That's the
I
coolest
know,
job description ever. Also, her
I
name
know.
sounds like she
She's
should have
delightful.
biscotti or lemon scones. Leslie Butterfield. Okay, continue.
She's delightful. And so we learn about how do you support a caregiver's emotional well-being and really thinking about that from your scope of practice, right? But everyone, I feel, and this is our premise of the work we do, is that anyone that works in this space needs to understand the foundation of perinatal mental health and really how you engage and what you say with these families really can
Matter.
last a lifetime.
Yes.
And then the second day of the training is about pediatric feeding disorders in infants. And so I've led that with a variety of people, but myself and another colleague, and then dietitians. Mari Mazzone and Sarah Harsh were part of that. And so we talk about the different domains of PFD as it relates to infants. And anyone attending these, they could be speech pathologists, they could be OTs, they could be PTs. They're also the family resource coordinators. They're also the intake specialists or the social work or infant mental health. And so this is why I'm coming up to this, is that we want them to hear the information and then think about how it applies from their lens and their scope of practice.
Yes.
So if they have a family say, well, I only feed my baby in this dark room and I can't have my toddler around, instead of helping them like try to figure that out at the moment, maybe they'll maybe you bring a basket of toys down for your toddler to play with during the feeding. Maybe that's what you do, but then also notifying the therapist, like, hey, this is what's happening. Like, we really need someone to come on board to be able to look at this because we know this isn't a typical feeding environment. Um,
Also,
anyways,
I start worrying about mom's postpartum depression and anxiety when they tell
yeah,
me. Okay, so folks, if you're listening, postpartum, screw the term baby blues, and I'm going to shout
yes,
that one from the mountaintops because
yeah,
it's not baby blues. That is passive and dismissive. The closest you come to dying when you're living is after you give birth. And a mommy told me that, one of my patients' grandmas, and you don't realize how close that is, that fine line, right? But the next question is, are we as practitioners following up with caregiver mental health when they're one, when they're two, when they're three? Because we know statistically postpartum can last for up to, I think at minimum 2 years, but it can take some women's bodies up to 5 years to recoup the basic like density and some of those micro elements that they lost during like giving birth and growing a baby because they suck it out of us. And I'm not being facetious, but like, where do y'all go down the rabbit hole with caregiver well-being? What do y'all do?
well, we look at it as the foundation of care. So
Mhm.
what we're working on shifting is that and helping everyone be perinatal mental health informed is what we like to call it. So from the speech pathologist to the family resource coordinator to maybe the dietitian at an outpatient setting, everyone should be aware of what is perinatal mental health and how might it show up. It's similar to like PFD screening, right?
Mhm.
Like anyone can potentially screen and really help them get to that next level of care. So part of the hospital to home care framework is actually embedding emotional well-being support for those caregivers while supporting their feeding, while supporting their development. And some people might think, well, that's not within our scope. It
It is. It's
actually
under the
is.
psychosocial domain.
Yes,
Oh.
yes. And there's counseling. Did anyone take
Uh-huh.
counseling classes? And yeah. And so if you actually go back and look, and people will say, well, what does perinatal mental health have to do with feeding and swallowing and our role? And
Everything.
everything. everything. And there's actually research that talks about that there can be long-term impact on development if perinatal mental health is an illness is there, right? So if there's mental health challenges or emotional well-being challenges, it's sometimes a more approachable word for families. Can actually be harder for those parents, birthing parents or non-birthing parents, to absorb the information you're giving and then to carry it through. And it shows up everywhere. And we know that feeding is really one of the most basic interactions that parents and babies have, right? And they are learning, how do they regulate, how do they attach to each other, and every single experience, yep, just like those neural wirings with that infant, that connection. So each of those experiences that they have, like, I'm pacing my baby with the bottle, they're gonna respond, or I'm giving them this particular support when they're breast or chest feeding. I'm going to wait and see what they do. That give and take, it has everything to do with infant feeding and yeah.
Yeah, that's sometimes I laugh and joke and say I became a CLC just so I could smell other people's babies, but like that's also not wrong. So, I mean, but that those helping caregivers learn the attunement and how to grow their attachment. Attunement, y'all, is how do they read their baby? How do they read this little person? How does that little person read them, for lack of a better phrase? And attachment is how do you grow this relationship so that there's trust and honor and respect that goes both ways. And that doesn't stop when you leave the NICU. It doesn't stop when you leave EI. That carries over. I can tell you from private practice setting that I'm working at now, and I get them down into a couple months old. It if they don't have it when they walk in the door, if we're looking at Maslow's scale of hierarchical need,
Yeah.
I can't, language, cognition, academic skills are at the top, right? Like being able to dream and grow intellectually, that's at the top. But if they're down at the base where their psychological relationships have not been fully formed and they are more worried about who's paying the power bill this month, then
Yeah.
they can't focus on those moments because they're too worried. I know as a working mom, I will fully disclose, I always describe it as trickling over. When my passion projects trickle over, like yesterday, I spent honestly 5 hours working on passion projects, because I needed to have off tonight for Goose's birthday. Goose Danger Dawson is 12 today, and God gave us a purple sunrise and it's his favorite color. And so go team. But, I wanted, like, that carried over because some of those passion projects, like that's part of like my foundational needs because other people are relying on me, and it makes me fret on the attachment piece. Am I being a bad mom because I am working but not really working? It's volunteer, but it's working. Some of our caregivers don't have the luxury of having 3 to 4 to 6 months off after a baby's born. I will say this loud and clear. We are the only first world nation that does not have paid maternity or paternity leave. That is failing the birthing parent right out the gate. We don't, as a nation, have cost-effective healthcare or childcare that is safe. So you're asking these individuals who came the closest to dying while they're living to then turn around and they have to go back to work as soon as possible so that they can pay their bills. And yet we're still working on how are they feeding their child? Like, and then we wonder why there's mental illness and all of these components. But what you're doing and the team that you have built, this matters. This helps them. That's amazing. Have you heard of findhelp.org? I learned about it from Julia Ochuro and Julia. She's with Boston Children's. I can see her face. She's a lovely person. But findhelp.org, they have this very cool, you can put your zip code into findhelp.org and anything you need, you can find it down to like food banks or help getting your power bill paid. I think it's an amazing resource.
Nice.
Yeah. Yay. So what else amazing things are you guys doing? Also, I went to meet Mrs. Butterfield. I mean, not just because her name is amazing, but like have her on to talk about like scope of practice of her profession. Okay, but like tell me more.
Where do I go? Let's see. So I think going back to what you talked about earlier, of like, how do you build this in within, like, so when I'm doing outpatient feeding and swallowing evaluations and therapy in my direct service role at Seattle Children's, the way I build in like how supporting a caregiver's emotional well-being is really how I'm showing up in that space. And sometimes it really is just slowing down and taking a deep breath.
Co-regulating.
Yes. Yes. So co-regulating is like this co-regulation. If I can slow my body down, I'm going to help slow them down. And then that's going to give them the space and grace to be able to take what we're talking about and potentially use it in that moment and carry it over. And if I know, and I look at this from an equity standpoint of when I do my evaluations and therapy, I actually start them the same way and end them the same way. So like, here is, thanks for being here today. This is our evaluation is this long. I understand you're here for this. I really thank you so much for coming today. I imagine it was a lot to get out of the house or, however it might be in that is just recognizing them showing up and sitting in that space with me and ask them, what are you hoping to get out of our time together? And then really taking that question and their answer and tying it back to the end of our time together, because then that's me valuing their time that they've given me, right? So at the end saying, this is what you came in wondering about. Do you feel like we've addressed that big concern that you have as a parent, or are we on that next best step? And giving them like the top 2 or 3 things that we think we're taking away from the visit, talking about it, writing it down, and then giving it in a different way, and letting them know that this is a team, right? So I expect them to let me know if that was the worst idea ever or if it was the best thing ever and they need the next best step, really giving them the space to say, man, Tiffany, you were really off on that idea. It didn't work for us. Like I thought it would, but really it was awful. So giving them just that humanity and that of like, let's see what works for you. And it's not everything that I might say is not going to probably work, and that's okay. And then just naming, and I give everyone the same resources in terms of feeding. I give them Feeding Matters, right? I give them the development resource, the pathways.org. Fantastic. I can't say enough about it.
Don't know this.
Oh my gosh, it has beautiful handouts and videos, and I'll actually pull it up during my sessions if I'm
it's called pathways.org.
Yeah, it's amazing.
Oh, this is
Yeah.
lovely.
Yeah. So if I'm screening, like, what are they doing development wise, and they try to tell me about tummy time or their baby won't do tummy time in that moment, I might pull up that video to say, this is kind of what tummy time looks like in around this age. What are you noticing? And the parents will say, oh, wow, they really aren't there yet. Or, oh yeah, they're crushing that. So that just helps us create a better understanding, and gives them resource. And then the other resource that I give the families is the local or the state warm line. So in our state, it's called Perinatal Support of Washington. So there's a phone number you can call or text day or night to say, I need some help. And so really saying, I give this to every family. And the reason I do this is because the emotions and feeding go hand in hand. And I want you to have the resources and know that this is a common thing that you might find that you need that support, and that is a-okay. And I'm okay
Yes.
with big emotions as we work through this. This is part of how I create that space. So,
So is that perinatal support phone number, is that to help with like um depression, anxiety, those moments? Do they help troubleshoot like I can't get my
yep,
baby to latch, or did they work on the psychosocial piece?
the psychosocial piece.
Love that.
So, like, my baby won't stop crying. I feel really, really upset right now, and really just
Right.
giving them someone to talk with. And then they'll help them connect with the next level of resources. Um, yeah. So, creating that, this is what I do for every family, just to normalize that we can have these conversations about emotional well-being and that it does impact these interactions. So,
What you're describing when you do that with every family and at every session is baseline, this is what we're supposed to be doing with routines-based intervention. Like that's so folks, I know I have talked about this a billion times, but like I love fgrbi.com, family guided routines based intervention, but every single session starts out with the exact same, like, tell me what worked, tell me what didn't work, what changes,
oh,
like you go through, but you're seeking to understand how your strategies and suggestions play into this caregiver or caregivers everyday dynamics. And
mhm,
that's, I remember being told I was pacing a baby wrong, that every baby you had to take the bottle out, or every baby you had to tip the bottle a certain way. And if I didn't do it the same way consistently, I was doing it wrong. And one, every baby is different. There are general practices that we should be doing, but we have to learn the cues for each child
mhm,
because all of them have different etiologies, but also it's, and this is huge for the, I don't know if it's the ego or the id, but for that personality approach, it's about making sure the caregiver feels confident and successful in feeding their child. They get 30 minutes or 1 hour with us out of an entire week. If we're not pouring into that caregiver so they feel confident, then we have failed before we have started. And yeah, you might need to model it for them, like left side lying in an elevated position. But at the end of the day, are we passing that baby off like a hot potato to make sure the caregiver knows how to do it? And please don't drop the baby like an actual hot potato game because we had that as when the kids were little and this is frowned upon.
yeah, I think the each of those interactions is creating their confidence and competence and being their child's parent, right? So, and they come from being in the NICU where parenting is not typical parenting routines aren't there. And so Leslie will talk about how like all those obstacles to attachment start in the NICU and then they go home, right? And then if they don't have support, those families might be trying things with the feeding position or the environment, and then they might come to you or you might go to them and they will share like this is how I'm feeding my baby. And if they share and you're like, oh my gosh, that's not how we do it, think about that immediate shutdown that
Mm,
parent is going to have and that guilt. And we talk about like the three layers of conversation. There's actually what you say, there's the emotion behind it, and then there's that identity.
mhm.
So when you're saying, gosh, you're not pacing right or you're not positioning right, it's that, oh gosh, I feel shame or guilt. And then I'm a bad parent. So what
Yes.
if instead we approach that interaction like, oh, I see you've made some changes. Like, tell me more about that. Tell me
Mhm.
more of how you got there. And I'm wondering, and I'm curious. And so, and then when you're doing that pacing, like, oh, I'm noticing that your baby is getting raised eyebrows. Let's see if we tip it down. I'm
Mhm.
gonna hold the bottle with you. Is that okay with you? Really
Mhm.
asking that permission, and that really balances that power dynamic and really helps you be with them rather than doing to them.
Mhm.
And then that shifts that layer of conversation, right? So you're saying, "What happens if I do this?" And then the emotion is, "Oh, they're supporting me right now. I can learn new things." So, yeah.
Okay,
What
I
does emotions and feeding have to do with each other? Everything.
yes, and I know this is like NICU EI, but I got this kid on my caseload who is 7, and his family just does out of love and compassion. And bless his little Bubby's heart, he walks in the door, and I literally wrote a goal that he'll set the table because he just sat down and just expected everything to be done for him. And we had to start at the beginning. Now, I could have, you know, ruined this emerging relationship with the caregiver by going in and talking about like learned helplessness, because I know that that's
Yeah.
technically the title for what I'm seeing, right? But at the same
Yep.
time, this mom has a lot on her plate that she shared from like home life perspective and all of this, and she has gotten to this point because this is what has worked for them in order to survive.
Yep.
So now it's, how do I help mom learn to let go so that we can foster independence and make a new healthy relationship with mealtime? So folks, this isn't unique to NICU, to home health, to tiny humans, but going at it with grace, going at it with a help me learn, y'all, right? Because that's a
Mhm.
huge part of it. That goes across the life continuum. I don't believe that it stops at 18. It goes on through, but adults have a much larger larynx and much larger secretions, and I don't want anything to do with that, so I won't go there. Oh my God, honey, I could talk to you all day long, but honestly, I had another cup of tea and I have had pelvic floor therapy, but tea is one of those things that supersedes pelvic floor therapy and I got to pee again. But
Got
also
it.
we this is some spectacular information. So follow up one. In my passion project world, I co-chair the Pediatric Feeding and Swallowing Disorders subgroup for SHAV, the Speech Hearing Association of Virginia, with Ed Bice. I would be honored to have you come. It's passion project, so there's no monies, but we would be honored to have you come do an hour in service for our small group to learn more about like how this can be facilitated, like the practical, like these were the infrastructure considerations, because that's huge here in Virginia.
Yes.
But also I would love to host your team on a like couple-hour webinar for speech therapy PD. Like this would be to have like an interprofessional perspective. That would just be such a blessing for our profession. So please talk to them, think about it. Don't tell me Johnny on the spot, no, but you can say yes. And they'll pay you for that one, but Shav, we're free, baby.
This is a huge area, and I honestly understanding the emotional well-being and how to facilitate and support that within my scope as a SLP has really elevated my practice.
Yeah.
And yeah, wow, this has been an amazing way to start my day.
Thank you. Okay, I know somebody somewhere is going to be listening. You have made me cry 3 times today already, the most joyful, like Irish leaking kind of way. Huzzah for Stilla. They make really good mascara and eyeliner. Stilla does not pay me to say that. Okay, but um, how could somebody reach you? Are you comfortable giving out, like, do you have an Instagram handle or an email address? How could they follow up with you?
Yeah, so I'm kind of in the feedingconnections@gmail.com is probably the easiest way. But I did do a little handout, which at the top gives our website for hospital to home. I think it's hospital to home systems change. I always forget if it's what the yeah .org. That's another way to learn a little bit more.
Oh,
But I am all about these conversations and knowledge sharing and in this alter teach all learn mentality that we use in this echo model that we use. Like that is just like we all learn when we share knowledge. So I
Yes.
love these conversations.
Yes. Ah, yay. Oh, Barb, you're lovely. Thank you for joining us together. This was wonderful. Tiffany, thank you, thank you, thank you.
Thank you.
Folks, if you're listening, be sure to find us on First Byte Instagram, First Byte Podcast on Instagram. Aaron, I'm going to get this right. And then we also have a First Byte Facebook page. So if there's another topic or another speaker that you'd be interested in, message us through the chat boxes, because that's a fantastic way of reaching us. And folks, oh, I forgot. If somebody listening wants to make a donation, if they have a little bit of love money, and they're inspired, where would you recommend that they donate to?
Oh, I mean, the Feeding Matters is always a great place.
Mhm.
In terms of pain and mental health, I would find your local state organization and donate that way to really support that caregiver as well.
Yes. All right. So, folks, there it is. If you have love money, go for it. Every little cent helps. So, Tiffany, with a very full heart, thank you, thank you, thank you.
Thank you.